So I'm supposed to talk about the history of the Trans-Kambin approach for endoscopic spine surgery, which turns out is one of my favorite topics. Um, I'd like to just disclose that I'm a consultant for a number of device companies that specialize in minimally invasive surgery, including Eloquence. They make the endoscopic equipment that I use. So I think we've already heard why we're here, in honor of a very important pioneer, Dr. Parvis Kambin, who I met personally, and um, he, for somebody of his stature, is the sweetest, most humble, quiet person I've ever met. But he's truly impressive because he introduced us to this secret door, the secret passageway to the disc, where we can get there essentially in an unimpeded way. It's a small corridor, but that working triangle is the basis of a number of surgeries, including the entire field of transforaminal endoscopic surgery, and now the entire field of OLIF, interbody reconstructive surgery, all through that little opening, which is both a blessing and a curse for all those that have gone through the learning curve of working in Kambin's triangle. But that is an important thing that's been contributed to the field of spine surgery. And what I'm talking about is a procedure that I called LESS, L-E-S-S, lumbar endoscopic spine surgery, which you have to admit is a pretty cool name for a minimally invasive procedure. But what is it? And in terms of the history, it has what seems like a very unique history, and that's what I want to focus on. Because it is the oldest state-of-the-art procedure that I have in my arsenal, in my toolbox. And it's been around for probably 40 years, culminating in 1999 with a landmark study by Parvis Kambin and his coworkers. That was in 1999. That means that the work went on in the 1990s. That is 25 years ago. And still we're talking about this like it's new and exciting and investigational in some ways. And since then, not only Parvis Kambin, but a number of really smart, dedicated, what I call OGs, original gangsters, Parvis Kambin, Tony Young, my mentor, and a number of other people, Sang-Ho Lee, they're all here, but they're the originals. They're like the Yoda or like the um, the the Dark Sith Lord. They did a lot of work. And then a second wave of really dedicated surgeons came on. They're like the they're like the Anakin Skywalkers and the Obi-Wan Kenobis were the second wave. And we as a collective, we did a lot of things too. We all together did studies, improved the equipment, give talks, did lots of cadaver labs, etc. A lot of work has been done. And in fact, if you go to PubMed and you type in endoscopic spine surgery, the number of peer-reviewed published articles is staggering. If you can guess, it is in the order of thousands, like it's probably 6,000 now. If you compare that to XLIF, MIC-LIF, and microdiscectomy, combined, it's not even close. And when you start having that many studies, a couple of things happen. One, people start doing lots of systematic reviews and meta-analyses, starting with one in 2010. There's been multiple since then. And in 2018, they did a meta-analysis and a systematic review. And that's not the only one. So it's clear there's tons of data. And the first question, does a transforaminal, Trans-Kambin endoscopic spine surgery work? Because that's the first question that people ask, even to this day. And the answer is absolutely, positively yes. It's not perfect. It's like all procedures that has the benefit and the risk. It has people that are good at it and people that are bad at it, but all the studies say the same thing. It is highly effective, and it's as good, if not better, than microdiscectomy surgery, which that is probably the best surgery that we do. It's probably the best, one of the best surgeries, period, on the planet. Probably the only thing better is a total hip replacement and maybe a coronary angioplasty, but it is competing with the best surgery that we do, and it's still just as good. So the history that's interesting to me about endoscopic surgery is it's been around for so long, and we all think that it's so great because there's the group of people that have that do this, we are like evangelists. We're not like, oh, it's okay. You start talking about endoscopic spine surgery, and all of a sudden, people like me wake up and we're excited about it. So, what I think is interesting about the history of endoscopic spine surgery is that if it's so great, how come everyone is not doing it right now? And I think we kind of already know there's two main reasons in the US. The first is reimbursement. That's a topic that, I'm not that great at, and it triggers me. And the second thing, which I think is even a bigger deal, is the learning curve. Turns out the learning curve for endoscopic transfemoral surgery is very, very, very difficult. Way more difficult than other surgeries. So, I've been trying to teach people how to do MIST lift, XLIF or lateral surgery, percutaneous pedicle screws with navigation, and endoscopic surgery. And it is absolutely clear to me the hardest thing to learn is endoscopic surgery for a variety of reasons. And in a review of the learning curve, it ranges from 35 to 72 cases. That is way too many to drive adoption. It has to be a few. And eventually it will be taught in a fellowship program, but almost all new surgical technologies don't get adopted through fellowship training. It gets adopted through the community surgeons learning from other community surgeons that are pioneers in small courses, adopting it. And once it becomes almost the standard of care in the community, then the training programs start adopting it. Then they start doing the randomized controlled trials after it's already too late. So a learning curve that's anything greater than probably 5 is too much. So we have to ask, why is the learning curve so difficult? Because of those 5,000 publications, very few are about the learning curve. And almost all of them are just simply, the learning curve is difficult. Thank you very much. You have to dive deeper, because by asking the question why, that's the only way we can address the next question, which is how can it be improved? And in the interest of time, that is an entirely separate talk. But in terms of the history of endoscopic surgery, that is the thing that I found the most interesting, because I don't know of another procedure that is so promising, so awesome, procedure that I would do on myself or my family member if they needed this surgery. Why is it taking so long, and what can we do to fix it? So the learning curve is what we should be thinking about in terms of the history of endoscopic surgery moving forward through a Trans-Kambin approach, because we should use this opportunity to figure out how other new technologies are going to be adopted easily and quickly, because this is an example of how not to do it. So I know how not to do the endoscopic learning curve. I just have to learn how to figure out what to do. And that's going to probably be a lot more education, things like the society, and things have changed, because I could never do a conference like this and give a talk like this in the middle of my vacation up in the mountains with very little internet access, but thank God I have good Wi-Fi. And at the same time, we're just building better equipment, just like golf. Every year, there's a new driver. My brother gets a new driver, and he's now out driving me. And instrumentation helps. And then, just like in Iran and many other places, including the US, you got to practice. It's like any sport. You got to practice, practice, practice. And we need to figure out ways to do that. And then finally, we need to expand our mentorship program. And the days of the internet and Wi-Fi and high-speed access, where we can instantaneously communicate with people across the globe like this in real time through video conferencing, is tremendous. And we need to do a lot more of this. And that's why Hamid Abbasi is so great, because he's already doing all of these things. So we have a lot more work to do, but it's good work. It's work not to figure out what's working well, but to figure out how to get more people to do it well. So with that, thank you very, very much for having me.